Hey listeners, want us to let you know when new episodes are available? Simply hit the subscribe or follow button on the Next Breast Thing podcast, wherever you listen to podcasts. Also, join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
On this episode of The Next Breast Thing.
Last time I was heading off to the Mecca of the universe, Cincinnati, in January, which is always an awesome time to be in Cincinnati.
I went to see the cow, to see how pregnant she was.
So we're planning her second birthday party. It's a Chanel-themed birthday.
My current goal during upcoming tax season is to find ways to legally lower my taxes as a W-2 employee. So now I'm looking...
Our topic today is lymphedema, what the breast community needs to know.
I'm going to play devil's advocate. The question is the monitoring of this worth it? Is the juice worth the squeeze?
I'm not saying that means these programs are right to do or wrong to do, but this is an opportunity.
It's that super high-risk patient, somebody who I'm assuming is going to get an axillary dissection.
How many axillary dissections are we even doing anymore?
There is not one clinical trial that shows...
What about for the surgeons out there who don't have that access for the lymphovascular surgeon who then does have a patient? This is Carla,
Ellie,
Michael,
Susie,
Sitcha.
And Susan. Welcome to The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the entire breast community.
We're a group of devoted surgeons from different parts of the country,
Inviting you to journey with us into the science of breast.
through the heart and soul of our breast community.
from advances in procedures and patient care
To personal transformation, we're here to support you.
So, if you're part of the breast community and can't seem to find the answers, this is the next breast thing. Our topic today is lymphedema, what the breast community needs to know. But as usual, before we get started, we're going to begin with some professional and personal updates. So, Susan, what's new with you?
Well, that's a loaded question because there's always so much going on. But last time I was heading off to the Mecca of the universe, Cincinnati, in January, which is always an awesome time to be in Cincinnati. I was helping teach the fellows course for ultrasound and oncoplastics. And it is so encouraging to see the next generation, the future of our field. So encouraging, so interested in learning, and they're just so idealistic about it all, and it brings you back. It's just a wonderful experience, and it's why we love teaching, and we love the whole education program that American Society of Breast Surgeons puts on. It just revs you up all over again. Michael, what's new with you?
Well, I registered for the annual meeting. I got that done. I still might be in the early bird time, so that's going to be good. I've mentioned before, never missed a meeting, and I haven't even tried. It just so happens I don't have anything else to do. And I went to see the cow to see how pregnant she was. She wouldn't come over to me. The rest of the herd came over. She's lagging back. So I'm kind of convinced my cow hates me. So I don't know. We'll just see how that progresses over the next several weeks. Susie.
Man, I'm sorry to hear your cow hates you.
It's
I mean,
bad.
that's rough, and I hope you can get through that. I'm just still running and playing mahjong and trying to stay warm, and not a ton is new with me, doing some snowboarding, and that's how my winter is spilled on there. Sitcha, what about you?
I think I've mentioned before, I have 2 toddlers at home. My baby girl's almost 2, so we're planning her second birthday party. It's a Chanel-themed birthday. Got the idea from a former fellow. There's these cute baby Chanel dresses. They're not real, obviously. It was like $14.99 on Amazon. But whole outfit laid out. She looks at it every morning and she says, "That's my birthday dress." So she's just excited for that. We just had something for her that I don't know if any of you are familiar with. It's called a Mundan ceremony. In Hindu culture and many other in Islamic culture as well, it's the shaving of a baby's head. It's meant to signify the shedding of past lives, freedom to start your new life unencumbered by burdens of the past. So we just had one for her. We didn't do a full head shave for her. We had the religious ceremony, family and friends at my parents' house. It was really just wonderful. And we had a tough year in our family, so it was just a nice event for us. So between her mundan and getting ready for her second birthday, it's been all about my baby girl. What about you, Ellie?
I kind of jump around a lot. I am interested in tons of different things, but my current goal during upcoming tax season is to find ways to legally lower my taxes as a W-2 employee. So now I'm looking into real estate investing and doing some like short-term rentals. And so I'm learning about that. I'm kind of reading every book I can get. I'm going to a seminar that's for physicians who are interested in real estate investing. Has anyone done anything like that? Has anyone had any experience in real estate investing?
Legally or illegally?
Legally.
Oh, okay. Yeah, no.
Ellie, being a landlord is not
I know.
great always. And short-term rentals, as fun as they sound, it is so much work. So my advice is, if you're going that way, and I've done this, hire a company to manage it. You just can't do it on your own. And the goal is, you can't have one, you can't have two, you need double digits.
Right.
So you have to build so that if one's empty, it doesn't affect you.
Mm-hmm.
But you need that company to deal with it.
Gotcha. Yeah, in California, it's quite expensive to have more than one door. So I'm starting in California, and then maybe I'll go across the state when I'm more comfortable. But
You need a building.
I do. I know. I need a
That's the
multi-ply.
key.
Thank you. What about you, Carla?
Well, Ellie, I know you're a big podcast listener, and so I'm sure you're listening some different podcasts on real estate investing. I feel like there's a lot of good ones out there. And I'm glad I didn't follow such a her update was beautiful, but mine is a little bit more just about sports. And so I was worried about bringing this up at the last podcast discussion because I didn't want to jinx it. And if any of you are big football fans, you may understand. So I didn't want to speak about my team. However, I've been flying high because the Philadelphia Eagles won the Super Bowl. Just an amazing season. So for my Birds fans out there, go Birds. I also want to point out, just talking about podcasts, our podcast has reached over 47 countries. And our listenership or listeners have been increasing with each episode. So I want to thank the group here and also thank all of our listeners for participating, giving us feedback. We're all really enjoying this. And with that, I'm going to move on to our topic. So today we're going to talk about lymphedema. Breast cancer treatment can be life-saving, but it sometimes comes with long-term side effects, such as lymphedema. The condition can cause chronic swelling, discomfort, and even mobility issues. The good news is that lymphedema can be managed with the right approach. What I want to cover is a couple different aspects of lymphedema. I want to talk about how we diagnose lymphedema. There's a lot of different ways to do it, and I'm sure we have a lot of different opinions here. Risk factors for lymphedema and prevention, and then finish it with treatments and sort of what the future looks like. To start us off, I want to have a little bit of a historical perspective because I think how we look at lymphedema, when we look at rates of lymphedema, they've really changed over the last 10, 15, 20 years. So, Michael, I'm going to call on you to start. Tell us how lymphedema has changed over your time in practice.
Michael, I think Carla just called you old.
Well,
In a very nice
let's just
way.
talk about it. I've never had a patient with lymphedema. So theoretically speaking, if I were to actually have a complication like this, it's interesting. We still end up quoting some of the old data on this, that the lymphedema rate for an axillary dissection is about 20%. How I was taught to do an axillary dissection that is clearly the biggest cause of lymphedema, we were skeletonizing axillary vein and things like that. So I think the real number is significantly down just for a full axillary dissection. Maybe in the 10 to 15% range probably is what it is in reality. It's a real deal. We even see this, though, even with sentinel lymph node biopsy. I think Z11 looked at a 7% lymphedema rate in their patients. So as things have changed, we've left the axilla alone more and more. I mean, it used to be part of the cancer treatment. Now it's kind of to the point where we feel like it's mostly just staging. And now we're finding reasons to leave the axilla alone. With the sound trial, we're looking for folks that we can exclude. 9343, we're looking for folks that we can exclude, obviously DCIS. So it's an increasingly small number of patients that fortunately are going to be subjected to this. And it's interesting watching this over my vast multi-decade experience of this. Susan is basically older than me. She could probably speak to the same thing. Susan, what do you think?
Notice who Carla called on first.
Fine, thank you.
Just saying. As usual, I can debate you about this. Did you just make up the 10 to 15% number? Is that...
What do you make
or
that up?
you
I didn't make it up. That's
you have
my number's 0, but I've just seen that number out there.
historically for an axillary node dissection, it is about 20%. You've lowered that to 10 to 15%.
Because the caveat of we don't do the extent of axillary dissection that I was taught as a fellow. We tell our fellows and tell our trainees stay below the axillary vein. There's no reason to skeletonize that. We're after nodes here. We're not after skeletonizing this whole region. So I think the way that we approach even an axillary dissection has changed.
That is true. And I think maybe it's not quite 20%. I agree. I don't think there's a number out there, but I think what the important number really is that within 2 years, there is a percentage, I might just call it 20%, and it just goes up a little bit if they also add radiation to the axilla. But what I find so fascinating with lymphedema is because it's slow growing, that at that 15-year mark, those who have had the radiation and the axillary dissection, that rate goes up to like 46%. And that's astounding to me. And maybe that's because they had surgery at a different time period. Could be. But I think it's also just important to know, like, this is a lifelong thing that people need to be aware about, not be afraid about, but be in touch with themselves and be like, oh, did that swell? Is that a change? And I think that's the take-home message from there, is that it's not just, oh, after 2 years or after 5 years, you're in the clear.
So speaking of percentages and sort of what patients notice, how do we diagnose lymphedema? Because for patients that are thinking about that, and for physicians, because there's a lot of different ways to do that. So Sitcha, what do you tell patients to look for? And do you have a specific way that you or your group or hospital tests for lymphedema?
I agree. I feel like the incidence has gotten much less, but I feel like when we are doing axillary dissections, and I'm old enough to have trained in a period of time when I was skeletonizing the axillary vein as well, but I feel like even with measures that we take for prevention, I still feel like the rate is up there, 20% with an X dissection, up to 30% with the addition of radiation therapy. Measurement, when it's obvious, it's obvious. You see a patient with a swollen arm, a heavy arm, it's obvious. I find it always interesting that studies will talk about subjective versus objective criteria for lymphedema. Many women do feel the heaviness of the arm and the feeling of lymphedema without actually seeing a difference in measurement. Visual inspection is obviously one way of looking. I think it's amazing that you can do things like bioimpedance and volumetric displacement. The truth is, I think most facilities just don't have all of those options for evaluation. One of our network hospitals does bioimpedance preoperatively. It meets the COC and PBC criteria for prehab evaluation, and I love that. We don't offer that right now.
I like it when our patients who are going to have an axillary dissection or even a mastectomy, that they are at that appointment and they're getting measured ahead of time.
Yeah,
I think that's one way to really have a concrete answer, and you're not just looking at symptoms. And symptoms are super important, and I'm sure we'll touch on that later. Ellie, what do you all do?
We actually just launched our lymphedema program, and it does bioimpedance, just like you guys are talking about. And the most important thing is measuring them before surgery. Because no matter what, you might have swelling in that first 3 months, and that can falsely make you believe that there's something going on that there isn't. But if you don't have that pre-intervention number, then you're not going to be able to make that initial assessment. But that's been the hardest part, getting them attached to the pre-op visit and having the billing codes all worked out and stuff like that. But that has been super successful or helpful in our situation. And what they quoted us was if they can catch them after that 3-month period and you can intervene and have the lymphedema physical therapists start working with them, they could essentially lower the rate of lymphedema significantly, if not prevent it altogether. I've never seen that personally, so I'll be interested to see if it actually works, but that's what the company peddles at least.
Okay, Carla, can I jump in?
Yes, you have senior rights here.
Yeah, no. Well, okay. Oh, wow. I'm going to play devil's advocate. And I want to preface this by saying we actually have a program set up. We bring patients in. I would normally see a patient post-operatively every 6 months for a couple of years and annually thereafter. But with some of the recommendations are to monitor this more closely. So now you're bringing somebody in kind of off cycle, right? You're bringing them in every 3 months. The question is the monitoring of this worth it for the number of people that are actually going to develop lymphedema? And I got it to where I was only monitoring those people that had about a 10% risk or greater for developing lymphedema. So I wasn't doing the sentinel nodes, obviously, and things like that. Is the juice worth the squeeze on this? If we're taking care of 100 people, is it worth putting 100 people through the monitoring of all of this to find maybe that one that you can correct? I mean, we talk about this a lot and we make a big deal out of it. It happens to you. It's devastating. Should we? I don't know. Like I said, we've got a program and I look back at it and I go, what does this cost?
Remember, as physicians, we have to be financial stewards of the big picture of healthcare dollars. And what everyone, it's a pass-through, insurance companies will pay. No, eventually we all pay for this. My viewpoint of how we spend our patients' monies, honestly, has changed over the last 6 years, where I joined a high deductible plan. And I will tell you, there's good things and bad things about it. And my kids will even tell you, I think twice and 3 times before my deductible is filled, do you really need to go to that visit? How important is that visit? Because it's real dollars that we're spending, and we feel that. Some people have high deductible plans of $7,000, $8,000. Tell me, by bringing that patient in every 3 months, besides the fact that they have to take time off, the last stats are that about half the people in our country are hourly employees. They can't take an hour off. No one can go to a doctor's appointment in an hour. So it's a half day off for an hourly employee. That's significant. And then on top of that, they get a bill for what end purpose. Now, if they've had an axillary node dissection and they got radiation and they got chemotherapy and they're obese, fine. But are you going to have a whole program for that person?
I would just sidetrack for a second because we talk about a lot of different things here and talk about cost-effective analyses and where they come into play and how they're important to us as physicians, researchers. We know that the cost of lymphedema for one patient is significant. And we look at different interventions and what they cost and the effectiveness of them. And we compare what that cost is and obviously quality of life. Even minor lymphedema is tremendous. And so I'm not saying that that means these programs are right to do or wrong to do, but this is an opportunity to utilize those things, looking at effectiveness of an intervention, i.e. seeing these patients every couple months and sort of the cost savings. One of the things that you guys mentioned was prehab. Is that something that everybody here in this group is doing with patients? Do you talk to patients about prehab? What does it look like for you guys?
I do think that prehab is great for that specific patient. It is not every single patient who is undergoing breast surgery. It's not every sentinel node biopsy, which is the majority of what we do now. But if you have a patient who is at high risk for lymphedema, they absolutely should have prehab.
We start talking about what are the causes. We've already discussed that axillary dissection is a cause, radiation is a cause. Historically, playing golf was a cause, lifting weights was a cause, flying was a cause. There was an article that's old now, it's like 2012, and it looked like the only things, blood pressure were not included, IVs, needle sticks, it was having a BMI greater than 25 and getting an infection in that arm. and that's it. I've always kind of joked that I can't get the nurses to empty the drains, but they'll sure as heck put that sign over the bed, no blood pressure needle sticks in the left arm. Those are hard habits to break, but we've got data. So, I mean, the prehab is, can you get somebody to get to a BMI of 25? I can't get to BMI of 25, but there's very little that this patient can do on the front end in the time frame that we're dealing with. And, I tell them, hey, look, if you're going to be gardening or whatever, wear gloves. Let's try not to get an infection in that arm. Other than that, the causes are us, basically.
I think that's true, but I think also having that other point of contact with the prehab. I mean, we give them so much information in a visit, and having that break and being able to talk about skincare and how is range of motion and what is good, what are things to maybe avoid at a separate visit that is before they've had surgery, I think can be a huge impact on them. I think also information like, oh, if you think your arm is swollen, don't just go wrap it with an ACE or find a cute tattoo compression sleeve on Amazon. This is serious stuff. This needs to be done by someone who is certified and who can measure you appropriately. And first of all, determine, do you really have lymphedema or not? Or is it just post-op swelling? And so I think that visit can be really good for that as well.
COVID taught us a lot of things. We shut down, patients couldn't come in, and we started having all these online educational programs. So we started an online series for lymphedema. And if we're educating them about exercises and symptoms to look out for, why does a patient need to take a half day off of work on top of everything that they're going through? They're going through cancer treatment, and then pay for a visit, pay for a facility fee, have all these additional costs. Why not have a monthly online educational program for your patients given by your lymphedema therapist?
I'll play devil's advocate there for a second because
I love that role.
That's Michael's role.
Well, I would say that we definitely stress the prehab when possible, but we tend to pair that with a localization procedure or if they have a PAT appointment, because I'm located in central Indiana. We get a lot of patients from all over the state. I'm sure we're all sort of seeing patients, whether it's distance or just dealing with like traffic. So we usually don't have that as a separate standalone visit, or if they're coming back for teaching for a specific reason, we're able to pair that. So that's a nice way, I think, to kill two birds with one stone.
I'm just going to jump on that devil's advocate bandwagon for a second.
Are you devil's advocating my devil's advocate to Susan? Where are we?
Yes, it's careful patient selection. I agree. I don't think that resources are best utilized when every single patient is having cookie cutter care like that. But one practice I've had is just having every patient after an axillary dissection, whether it was planned or unplanned, get that education session just so they know who to reach out to if they're starting to notice symptoms, if there's a problem, if there's a question about it, just so they know what precautionary things they can do, kind of like the education that Susan mentioned. Love the idea of doing the monthly one. But I think what we really need to underscore is, and I think somebody said it earlier today, is the benefit of early detection. I think Ellie said it. Early detection has been shown to have improved outcomes overall. And so in the right situation, with the right patients, with the right resources, I think that getting people tapped into the lymphedema therapy system early can really be beneficial to them.
And I think Susan and Carla, all of us have brought up these good points, like where is your patient coming from and what are your resources and what does it mean for them? And some people do great learning online and other people are never going to log on, or they can't figure it out, or it's not the great learning environment for them and they need that personal attention on there. So I think having these resources is great. And I think having that personal attention and really understanding what to look for is important. I think as providers, it's important to let people know, like, wow, you can't see the veins on one hand that you operated on and you can see it on the other. And is that significant? What symptoms are they having? And being able to have a discussion about it, I think is important. You know, anybody can hang a lymphedema shingle. There's not like this board for it. And I think it's really important to understand this elevated training that a lot of these people have gone through, that it's not just, oh yeah, use lotion and wash good and don't get a bug bite and watch temperatures. I mean, this it can be really complex when they're receiving that decompressive therapy. So I think we're kind of talking about two categories. It's like the education ahead of time or after the fact, and then who needs and is benefiting from those visits.
I think we've got data that shows that bioimpedance probably is your best bet for the earliest detection with what we have right now, whether it's water displacement or tape measures or perimetry or whatever. So it's good for detecting early. And I think if you can detect early, maybe you can prevent, or certainly you could halt it at an early point. But then let me wrap that with kind of what Susan was saying earlier is can you afford a program where you're being selective to have bioimpedance? If you're only selecting out the high-risk patients and only testing those folks, can you make that work economically within your practice? And I don't know the answer to that question.
I think that's a good point. So we've talked about different ways to diagnose lymphedema. We've alluded to some risk factors. We've talked about axillary surgery and radiation, high BMI, and we've talked about some ways to prevent or potentially catch it early. I'm going to turn to you, Ellie. Anything else that you talk to patients about or that's available for patients to prevent lymphedema? And then we'll move on to treatments.
We just, at my hospital, got available a microsurgeon, somebody who can offer these preventative lymphovenous bypass surgeries. A really amazing tool to have. And myself, I've tried to navigate in my practice. Okay, it's a lot for her to set up the microscope. Scheduling is tricky, to get us in the same room. It's, again, the same discussion about who might need the bioimpedance. It's that super high-risk patient, somebody who I'm assuming is going to get an axillary dissection and radiation. That's a slam dunk for a lymphosurgery. But a lot of insurances consider it experimental. Not all insurances cover the lymphovenous bypass. So that's something that's tricky to kind of navigate in your system, that type of procedure. But that is something, at least at my institution, that has now become available. And it was also something that I saw during my fellowship. We did have surgeons that were doing that regularly, and it did really help patients. And a lot of them were improved from having those surgeries. But I know that's a very hard plastic surgeon to recruit and to have available. So it's one of those tough things that if you're in the middle of nowhere, you're not going to have access to that.
Is anybody else doing this on their own? I know that the S-Lympha trial made it a little bit easier because you're just sort of patching the lymphatics into the venous structure. I think that's something that we could do. Is anybody doing that?
I was just reviewing some of the lympha papers, and there's a lot out there. There's a lot of discussion about it. I do think the microvascular trained surgeon is probably going to be your best option for your best outcomes. It would be nice for the dunking technique to work, but I think there's a reason why they're often well-trained and using microscopes to be able to kind of get us the outcomes that we want. The papers that are out there are interesting in how they diagnose lymphedema, because there's about 5 to 10 different ways that they diagnose lymphedema in all these papers that are slightly different. There's a lot of variability, but there's an ongoing prospective randomized trial that we're waiting on to really give us the full data about how beneficial lympha is going to be for our patients. So I think we await that.
We offer a lymphovenous bypass with a microvascular trained plastic surgeon at the time of planned axillary lymph node dissection. I love that we do because it makes me feel better. I think it makes the patient feel better, but I'm not sure that the studies, I think a lot of the results are inconsistent with inconsistent and variable measurements, and I'm not sure that the data is completely supporting it. I know that there's good data supporting the use of lymphovenous bypass for reduction in pre-existing lymphedema, but as a preventative technique, I feel better offering it.
How many axillary dissections are we even doing anymore? We're having trouble getting our fellows 10 axillary dissections a year. These are big programs that we're talking about on a pretty low number of folks. Maybe you guys are vigorously doing these and you have a huge population, but this is a procedure that's going away. I'm not sure we should spend the time or money on putting together a huge, expensive program.
I don't think it's going away quickly enough. We have to remember and I know it's off topic, there is not one clinical trial that shows that removing lymph nodes changes outcome, except increases lymphedema rates. But it does not change outcome. We have studies from decades ago showing us that, and we keep doing and redoing more clinical trials to come to the same conclusion. I do very, very few axillary node dissections. The ones that I do are all planned. I do them with my microvascular plastic surgeon. Do I know that it makes a difference? I'm not sure that it does. I don't know. We don't do enough to even be able to follow our own patients to get our own data. But I agree. I think axillary node dissections are going to go away. I think sentinel lymph nodes, we will be doing less and less. So even that will be less cause for lymphedema.
What about for the surgeons out there who don't have that access, for the lymphovascular surgeon who then does have a patient with lymphedema, about doing it post-op? The lympha procedure, as advertised, is really more of a preventative measure. But this is a good transition because there are similar surgeries that can be done for treatment, but I think they are different. And so as we transition into treatment of lymphedema, I think there are a lot of surgical options that our plastic surgery colleagues can offer. But probably similar to you guys, I don't know that I've ever referred a patient to have one of those procedures. And while we're talking about lymphedema related to breast cancer, so of course we're talking about arm lymphedema. We know that other cancer patients can get lower extremity lymphedema, and I would imagine a lot of those lymph node transfers are being done for that.
It's interesting you brought up referring. I had a patient that was a concert pianist, and of course, she developed lymphedema, and it was terrible. And we tried everything that we could do locally, and I referred her out, and it didn't work. But she was pretty obese, and she lost a tremendous amount of weight, and her lymphedema resolved, which was weird. The surgery itself to fix the lymphedema didn't work, but her getting her BMI pretty close to 25, oddly, was the thing that took care of her lymphedema. That's something I didn't see coming. That's my N of 1. I've never heard of that before or seen that before, but I watched it with my own 2 eyes on her. And so interestingly, that is something that I would hang my hat on for other folks, is that if you've got a situation like that, that maybe massive weight loss, or maybe not even massive weight loss, but just significant weight loss, cured her lymphedema.
Yeah, I think it can help, but there actually is a study looking at if people lose 8% of their body weight, did it make a difference? And sometimes it did and sometimes it didn't. And that's after they have the lymphedema. So I think there's a lot of benefits to weight loss or being more appropriate body weight. And we've discussed that before, but I think this may work. If it doesn't work, you've received other health benefits from it, but I don't think that's going to be an always statement.
Well, I think the weight loss thing, again, we have talked about it before as a group, and I'm sure all of us think about what we talk about and go back and go, gosh, I wish I would have talked about this. I think about this afterwards. And one of the things when I talk about weight loss with my patients or diet is that while they may not directly benefit you right this moment with your breast cancer treatment or your lymphedema, what is the number one disease that women die from? Heart disease. And heart disease is related to obesity, metabolic syndrome, high cholesterol, all of these things. If it might help my lymphedema, that's great, but it also has these other benefits as well. So what about exercise? I remember when I first came in practice, I had worked with a researcher in this area who had just published a study on weightlifting for patients who'd had axillary lymph node dissection. So I don't know, any of you guys used to tell patients not to lift any weights after axillary lymph node dissection? Because for a long time, that was sort of the recommendation.
I actually had this lady who had an axillary dissection 20 years ago, and she's pretty thin, and you could literally see her whole axillary anatomy through her skin. You know, she clearly had her axilla just cleaned out, skeletonized. And she did push-ups every day after her surgery. And she also had radiation. She had recurrences. You know, her axilla has been damaged multiple times. But she said, I have done push-ups ever since I was able to tolerate the pain about 4 weeks later. And she's never had issues with lymphedema. This is also an N of 1. So I don't know if anyone else has had that experience, but it was so interesting to me. She was vigorously weightlifting. She was building muscle, and she did not develop lymphedema when it looked like she would have like a 50 to 60% chance of developing lymphedema.
I encourage patients to take measures to improve their health, including weightlifting, even after an axillary dissection, even with lymphedema. I don't consider that as a risk factor, and hopefully I'm not mistaken in that. I think it was when I was a fellow, there was a randomized trial that came out. It was published in New England Journal of Medicine, where the weightlifting group actually had a lower incidence of lymphedema than the non-weightlifting intervention group. So I've just always kept that in my mind.
Before we close, I wanted to go around, see what your messages are for the future. You know, if we're doing the Next Breast Thing podcast in 2035, what are we going to be talking about? So, Michael, since I started with you, I'm going to start with you as we finish off.
I think the key is awareness. We spend a lot of time post-operatively talking about their path report and things like that. And maybe their follow-ups are looking at their mammogram or doing a physical examination. So I think awareness, it's going to be tape measure, whether it's going to be notifying the patients or whether it's bioimpedance spectroscopy. I think being on the radar that this is something we need to look out for, because early intervention, if we can't prevent it, we could certainly keep it from progressing. And I think that's going to be the key, is we want to stop progression. You can't do it unless you're looking for it.
Great point. Susan?
I think in 2035, we will not be talking about lymphedema.
There you go.
That's my take home, the point to remember. But I think a lot of this goes back to treating the right patient at the right time with the right treatment. I don't want to screen 200 patients and have them come in every 3 months where they would not do that. And I'm not really helping them to find that 1 or 2 patients. Let me figure out who's at highest risk and then target that population. I really think that we have to pay attention to financial toxicity, to cost benefit, and to quality of life issues. And if we think that bringing someone in every 3 months adds to their quality of life, I think we need to reevaluate that. Lymphedema decreases quality of life, but so do a lot of other things. So target the right patients.
Susan, I love that. You've got your business hat and your white coat on. Sitcha, what about you?
It's such a debilitating disease, but fortunately does not affect most of our patient population. Primary prevention, if you don't need to do an axe dissection, just don't do an axe dissection. We're all doing less and less. Yes, I agree, primary prevention, but I don't think it's going away. And I think just improving our ability to detect and treat, it serves our patient population and our survivorship patient population well.
How about you, Ellie?
My main takeaway from this discussion really kind of spurned thinking about the education aspect. I feel like sometimes I am a little bit exhausted after doing the breast consultation, and the lymphedema I might run out of steam talking about. And that's not fair, especially if a patient is at high risk of this. And I loved Susan's program that they have where they do a video for the patients or have a class once a month for those people that can't do the video. Knowledge is power, and our patients are thirsty for good information. And the more they know, the more they can tell us if they're developing symptoms and stuff like that. So I'm definitely going to rethink my practice around the education around lymphedema. And yes, I agree, in 10 years, this will be a moot point. We'll be on to something else.
Great. And Susie, we'll finish it out with you. Number one, we got to treat cancer, and we're treating it according to guidelines. And then I think the second thing is that lymphedema is really terrible for those people who have it. Not a ton, but it's really terrible. But they can't live in fear of, oh, I might get a bug bite. I might travel and what's going to happen. But getting them connected with really reliable resources that can help them through that, help them through the treatment in order to make more successes in the rest of their journey. And that this can be lifelong for some people, and it can come up later, but that we're still there as the team behind them and to help direct them to appropriate resources. Great point. I agree with Susan that my goal was in 2035, we wouldn't need a podcast on lymphedema. So stay tuned. To our listeners throughout the breast community, we're so excited. So many of you have joined, and so many more continue to join each week on this journey. And we look forward to hearing your comments about this episode, what else you want to hear. And we'll see you next time on the Next Breast Thing podcast. We look forward to connecting with you on the next episode of The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the breast community.
Join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
Finally, The content within the Next Breast Thing podcast represents the views, thoughts, and opinions of the co-host and may not necessarily reflect the views, thoughts, and opinions of the American Society of Breast Surgeons.
Until next time, this is Carla.
Ellie.
Michael.
Susie.
Sitcha.
And Susan. And always remember, if you're part of the breast community and can't seem to find the answers, this is the next breast thing.